Good morning, Dr. Supenu, distinguished panelists and attendees. I'm Dr. Fabian Obakeye. I'll be making a presentation on the work that was done at the University of Abuja Teaching Hospital, titled Evaluation of Urinary Calcium Creatinine Ratio in the Prediction of Preeclampsia. Hypertensive disorders is said to occur in 5 to 10% of pregnancies, and is associated with significant maternal and perinatal morbidity and mortality. Preeclampsia, which is a common type of hypertensive disorder of pregnancy, is a multi-systemic syndrome defined by the development of new onset hypertension, persistent systolic blood pressure of 140 millimeters mercury greater or after 20 weeks of the gestation, or a diastolic blood pressure of greater or equal to 90 millimeters of mercury after 20 weeks of gestation in a previously intensive patient. The World Health Organization approximates the incidence of preeclampsia to be 7 times higher in developing countries. About 2.8% was quoted, as compared to that of developed countries, meaning the disease burden in developing countries is quite enormous. In Nigeria, it is responsible for as high as 32.4% of maternal deaths in some regions, with adverse perinatal outcomes include preterm and small for gestational age babies. Despite its high prevalence and a major cause of adverse maternal and perinatal outcome, the pathophysiology of this multi-systemic disorder is still poorly understood. Renal function changes are seen in asymptomatic women in whom preeclampsia will eventually develop. Some researchers have documented that hypocalciuria was associated with preeclampsia and could be thought to be a risk factor for the development of preeclampsia in pregnancy. The justification that since primary prevention of preeclampsia is not possible, and as the etiology remains unclear, secondary prevention to identify pregnant women who are at risk of developing hypertensive disorders in pregnancy, to avoid the adverse sequelae and institute timely intervention becomes a researchable field. Therefore, the prediction of preeclampsia in patients, prediction of preeclampsia in patients is extremely essential to identify early detection and prevention of complications. A diversity of biochemical and biophysical markers based primarily on the rationale of the pathophysiology and pathology of hypertensive disorder due to the pregnancy have been proposed for predicting development of preeclampsia in later pregnancy. However, these various studies have been challenged with a lot of limitations, such that it may not be cost effective, it may not be readily available, and interpretation of results has also masked their use. The currently used diagnostic criteria are elevated blood pressure of greater or equal to 140 millimeters of mercury, or elevated diastolic blood pressure of greater or equal to 90 millimeters of mercury after 20 weeks of gestation in a previously normotensive woman. In a previously normotensive woman after 20 weeks of gestation, and a proteinuria of 0.3 grams or more in a 24-hour urinary sample collection, which is corresponding with 1+ or greater in a urine stick. Although this 24-hour urine protein is diagnostic, but the process of sample collection is quite cumbersome and tedious and may not be feasible in a busy facility. But none of them have been proven ideal, either due to increased incidence of false positivity or their intricacies in results interpretation. Although the specialized tests have been reported Specialized tests have been reported in the diagnosis, in the screening for patients with preeclampsia. The first alternative method of this stick, although suitable in peripheral health centers with limited facilities, is inaccurate and therefore unreliable as a screening method or a diagnostic test. The limitations in these existing screening tests have heralded the interest in urine calcium creatinine ratio, which is inexpensive and easy to carry out. However, its usefulness in predicting preeclampsia in Nigeria, where the disease burden is quite high, is yet to be validated. That was the justification for this study. The aim of the study was to determine the predictive value of urinary calcium creatinine ratio in a sports urine specimen in pregnant women with risk factors for preeclampsia. My objectives were to determine the effectiveness of urine calcium creatinine ratio as a threshold value of less or equal to 0.4 as a predictor for development of preeclampsia. The second was to determine if there was a more applicable threshold value for the urinary calcium creatinine ratio in my environment, which was Nigeria, using the receiver operator characteristic curve. And third was to determine the maternal and perinatal outcomes. The study was a prospective course study, and it was conducted at the University of Abuja Teaching Hospital, Gwagwalada, Abuja. The study population comprised of pregnant women at a gestational age of between 20 to 24 weeks. The gestational age was estimated using their last menstrual period, or if they had a first trimester scan with risk factors for preeclampsia, attending the antenatal clinic of the University of Abuja Teaching Hospital. Eligible participants were counseled about the study, and a written informed consent was obtained. No dietary alterations were recommended. They had their weight, height, and blood pressure and urinalysis done, and urine was collected using clean catch method, so assay for both calcium and creatinine ratio. Voided urine samples were collected from the patient in calcium-free vials, 20 ml container, for estimation of the calcium creatinine, and this was done at booking. The urine samples were divided into two aliquots, one for calcium assay and the other for urine creatinine estimation. The one for calcium was acidified with hydrochloric acid to prevent precipitation of the calcium. The urine calcium creatinine estimation were done by cresofetalin complexon test and modified Jaffe's method, respectively. And blood samples of 2 ml were collected in lithium heparinase container for serum creatinine assay to exclude background renal pathology. Patients were followed up with a standard model of antenatal care follow-up schedule, and signs and symptoms of preeclampsia were noted and looked at for. Routine examination of their blood pressure was done, serial weight, fetal growth, and urine albumin by dipstick method until delivery. The data was prospectively collected from eligible participants, and these were done using structured questionnaire that was completed by both the researcher and the research assistant as at the time of booking. Data analysis was done using IBM SPSS 25. The results showed that 140 patients were recruited from the study. However, the results of 137 were analyzed as 3 were lost to follow-up. The mean gestational age for this study was 28 years, 28.55 plus or minus 5.1. A majority of the parturients were nulliparous, accounting for 46.7% of the parturients. The prevalence of preeclampsia in this study was 9.5%. This was a table that showed the sensitivity, the specificity, and the positive predictive value and the negative predictive value. When this was subjected to statistical tests, it was statistically significant with a p-value of 0.001. This was also a a table showing the analysis that was done when it was subjected to statistical analysis. The summary of it was that the sensitivity derived from the test was 84.6%, the specificity was 99.2%, and the positive predictive value was 91.7%. The negative predictive value was 98.4%, and the diagnostic accuracy using calcium creatinine ratio as a marker for prediction of preeclampsia was 97.8%. The receiver characteristic curve, ROC curve, was used to determine a more applicable cutoff. And this was done by maximizing the sensitivity and optimizing the specificity. There was a blue line here that helped to achieve this aim. The blue line on the curve was noted at the point of obtaining maximum sensitivity closest to the left-hand corner of the coordinates. And when this was done, the cutoff of 0.05 was shown to be more appropriate, as more patients were likely to develop preeclampsia above this cutoff, while patients with below this cutoff, while patients with a greater value of 0.085 were less likely to develop the disease, as compared to what was had been recorded in the literature, where 0.04 was used as a threshold in prediction of patients that were likely to develop preeclampsia. Further results, among the 13 patients that developed preeclampsia, this was the fetal maternal outcome. 2 had spontaneous vaginal delivery, 1 had induction of labor, and which accounted for 76.9% of the parturants, and the had cesarean section. This was statistically significant with a p-value of less than 0.01 when compared with other women who did not have preeclampsia. The number of babies admitted into the special baby care units were 5, which accounted for 27.8% of babies and whose mother had preeclampsia. There were 3 deaths, and 2 of those mothers had preeclampsia. This was there was statistical significance in the mean birth weight and also admission into the special baby care unit and perinatal mortality between women who developed preeclampsia and those who did not, with a p-value of 0.019 and 0.001 respectively. The conclusion, area under the curve was a measure of the accuracy of the quality of the diagnostic test. For urine calcium creatinine ratio, it was 0.96, which indicates that the test is a reliable test. And from this study, it was recommended that urine calcium creatinine ratio was a good predictor of preeclampsia in patients with high risk, and should be considered as a screening tool because it's affordable, is non-invasive, and effectiveness of the marker when compared to other methods like 24-hour urine estimation and use of biochemical markers, or the use of uterine artery Doppler velocimetry, which may not be readily available in low resource setting, thus giving them opportunity to be screened and necessary intervention to be instituted on time. The limitations of this study was that dietary patterns of the patients were not determined as at the time of recruitment, and this may have had impact on the outcome with respect to the calcium content of their diets. Patients with previous history of preeclampsia who were not on low dose aspirin as at the point of recruitment, as at the point of determining, as at the point of identifying them as patients with risk factors, could not be recruited into the study because of the departmental protocol to institute low dose aspirin for them as at the time of the study. And also the non-availability of a point test strip. This will have aided prompt testing and reduced time loss in obtaining results. Thank you all for listening.